Hello, I'm Dr. Brook, a board-certified dentist in both the American and European Veterinary Dental College, as well as a fellow in the Academy of Veterinary Dentistry. This lecture will be about feline oral pathology, or feline oral diseases. We'll talk a little bit about medicine, but mostly about things that you're going to find in your feline mouse, other than gum disease, which is covered in a separate lecture. Hello. Getting ready to start. Hello, I'm Dr. Brook, a board-certified dentist in both the American and European Dental College, as well as a fellow in the Academy of Veterinary Dentistry. This lecture is on feline oral pathology, the unique things that we will find in the mouth of cats. There are some overlaps between dogs and cats, but there are quite a few unique things in feline dentistry, and that's what we're going to focus on here. If you would like to take home some of these pictures and more information, all of this is covered in one of these two books, if not both. They are available through either of these places. They're on our website, which is dogbeachvet.com. All right, couple quick rules. I've been doing feline dentistry a long time, and I cannot stress this enough. Cats aren't small dogs or small people. They have very unique problems. A couple of them, lip trauma from maxillary canine extraction. Can you see that in dachshunds? Yes, but we see it way more often in cats. Can you see eosinophilic granulomas in dogs? Yeah, but you see it in cats. And uremic ulcers we'll see more commonly in cats than dogs. And they are less affected. Note that doesn't say not affected. It says less affected by the common things that we see in our canine patients, which is root canal problems and gum disease. But they do get it. I'm not going to talk about gum disease in this lecture, but I am going to talk a little bit about endodontic disease. I think if any of you guys have been treating cats long enough in any way, they don't read textbooks. They don't. They're much more challenging to treat, I find, than dogs are, because they just don't follow the rules like dogs do most of the time. And things that work for one cat may not work for the next one. And they often have unusual presentations, so be prepared for your initial assessment to be wrong. And we're going to get towards the end of this lecture talking about inflammatory disease. Cats get a lot of oral inflammatory disease that all look the same. So biopsies are going to be pretty important in your feline dentistry. And I said this with dogs, I'm sure. Cats don't stop eating because of their mouth. I cannot tell you how many cases are referred to us and they're like, well, he's not eating. He wants to eat. He goes up and looks at it. Well, if you're got the flu and you're nauseated, do you still go to the kitchen? Do you still open the refrigerator and go, I really need to eat, but I just can't? Or do you just eat that Ben & Jerry's, cookie dough ice cream because it tastes good? If someone slapped down Brussels sprouts, would you be like, oh yeah, So here's the thing. The vast majority of time, 99% of the time, if an animal's not eating, the cat is got another problem. So always work that up. I see it all the time. So please, 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 please work it up. The exception to the rule is lymphoplasmacytic or caudal stomatitis. So you need to work these animals up. Critical, because cats are really going to hide their problems, especially respiratory. So do a good listen, and chest x-rays are not a bad idea. You talk about that at the bottom, because remember, only over 50% of patients over 6 have significant findings on chest films. They do. There's not a study, but that we did them for a long time. So you definitely need a complete blood panel. Get a CBC, T4, especially in your older cats. Definitely check the kidney values. Urinalysis. My significant other is it works for a diagnostic lab, and she's like, it's called liquid gold for a reason. There's so much information on a UA. SDMA is a very sensitive marker for early kidney function, so it's a good idea. And honestly, it's not on the slide, but we started to do cardiopet ECGs on all of our patients, and we find some stuff. So it's a good thing if you ever want to ask me about it. All right, so let's talk about oral disease. Endodontic disease, we've talked about with dogs for the most part, and they break teeth all the time. Cats do break teeth. There's really two big differences, and the first one is the most important. The root canal in a cat comes millimeters from the root tip. You have to assume that any loss of tooth structure on a cat tooth, especially the canine, will expose the root canal. So I don't care. It's like, oh, it's just a little bit. Yeah, you need to get that pet under anesthesia, and you need to probe it. So really minor fracture, right? Oh, no problem, right? Here's the x-ray. What you can see here, huge area of tooth loss, huge area of bone loss. This tooth right here, that little tiny 2 millimeter chip, was enough to expose the root canal and cause infection. So anytime you see a little tiny chip fracture in a cat, you need to get them under, you need to probe them, and you need to x-ray them. Okay, so that's the big thing. So any fracture in a cat needs to be evaluated. The other thing is, and this isn't a huge deal in general practice, but it is for us in specialty practice, or if you guys wanted to be referring out for root canals, long-standing fractured teeth in a dog will cause a lot of bone loss, but not tooth loss usually. Cats, for whatever reason, maybe they're trying to reject it, will eat away their actual tooth. And that means that root canals aren't going to work. So here's a cat, fractured tooth, right? We hate taking out lower canines in cats, right? Everybody does. I do too. So I wanted to root canal this tooth. Well, here's your x-ray. So here's the more normal one here on the right side of the screen, left side of your patient, nice and normal. We start seeing over here where you got the periapical lucency, sure, but now you're starting to see that tooth being eaten away. My anecdotal experience is that these don't do well, and it was actually backed up by a study. I'm not sure if the study's been published yet, but UC Davis with some of the other residency sites did a study when they said that basically when you start getting root tip resorption of these cats, the prognosis of root canal goes down. And I agree with that wholeheartedly. So, if I saw this on x-ray, I would I wouldn't say we can't root canal it, but if we can get to it earlier, it has a better prognosis. So again, cats don't get as much fractured teeth as dogs do, but they do get root canal disease, and they need to be evaluated. And root canals are straightforward in cats. They do really well. So I would strongly recommend that those get done. We'll talk about lip catching in a little bit when it comes to cats, and why we don't like to extract upper canines, give it an option. All right, one of the more common things you're going to see out there is tooth resorption. Tooth resorption, depending on the study that you read, somewhere between 40, some down to 20, but some is up as high as 70% of cats will have a tooth resorptive lesion. And so here you can see it right here. You can see that this lesion, that little blip, and I will tell you, cats don't get gingival enlargement very often. So when you see this, that little bump right there, that's my sign that this cat has got a tooth resorptive lesion. So if you're doing an oral exam on this cat, he needs to go under anesthesia and get that evaluated. Even though he doesn't need a cleaning, he needs this because this is agonizingly painful. So if it's all below the gum, we'll talk about that in a minute, a little bit more. But if you take an x-ray and you see the resorption of the roots, but you take a fine tooth comb around the tooth and you can't find any resorption clinically, we don't think it hurts. So we generally don't treat them. But once it gets up into the crown of the tooth, it hurts like you know what, and it needs to be treated. It needs to be extracted. We're going to talk about extraction versus crown amputation in a moment. But really, if you see gingival enlargement, cat needs to go under, cat needs to be treated. Okay? So here's a normal dental radiograph. Anyone out there like cat extractions? I'm sure there's one or two of you sick people out there that actually like it. And I've never asked an audience that if they like tooth resorption, that the people that say they do don't have dental x-ray. You got to have dental x-ray. And that's just our theme. You have to, especially for kitties. So this is a normal dental radiograph. Okay? If cat x-rays look like this, you wouldn't hate cat extractions because he's got a nice periodontal ligament here. See that black line all the way around these teeth? That's the periodontal ligament. This all looks really good. Okay, no problem at all. These would be easy extractions if you had to take them out. Now you don't need to, but they would be easy extractions. Okay, so 2 reasons to take x-rays in cats. Number 1, find these lesions in the first place. So this cat had just had a dentistry and they found this lesion here, this cancer. It was benign, thank God. But you see this little bump right here, that little redness there, but you can really see it here. That little bump, I'm telling you, there's a TR sitting underneath there. Oh, and by the way, it's not odontoclastic resorptive lesions. It's not cat cavities. It's not, resorptive lesions. The current terminology, at least for this week, is tooth resorption. Okay, so dogs get it too, unfortunately, but this bump is tooth resorption or TR. And don't believe me, here's your x-ray. So that's that little bit that you can see. You can see all these roots being destroyed. So that's one reason, find them in the first place. But number 2, how do you treat them? Because we've all heard of tooth resorption, but most veterinarians use it way too often. Veterinary dentists don't use it all that often, but it's variable. This is what ankylosis looks like. Okay, you don't see that periodontal ligament space running around these teeth anymore. You can see a root canal there, but this is complete ankylosis. These teeth are being resorbed and they're fused to the bone. You're not getting these teeth out by standard elevation. No matter how much surgical bone you take away, it's going to break, and you'll probably break the jaw before you get the tooth out. So this is a type 2 tooth resorptive lesion where you have replacement resorption. So this would be a candidate for somewhat of a crown amputation. You can still see root canal to here. So I would do what I call a modified crown amputation, which is I would cut the tooth crown off down to about here. And then once you can't see root canal anymore, I would let the body continue to resorb that. We'll talk about that more in a sec here. All right. Like I said, 2 classes of tooth resorption. I don't usually talk about type 3 because type 3 is a combination of type 1 and 2. But type 1 does not have replacement resorption. Type 2 does. So you can see here, wicked resorptive lesions here, right? Wicked lesions. Here's your x-ray. Wicked lesion here. Big Pac-Man chomps out of these teeth. But completely normal roots, completely normal root canals, completely normal periodontal ligaments. These can not be crown amputated. If you do, you're leaving root canal behind, you're leaving the tooth behind. So when you have a type 1, it has to be completely extracted. Good news is, it's going to be a pretty easy extraction. I mean, you're just going to go in here and elevate it. These don't have ankylosis. They're pretty easy. This one might break, because it's been damaged here. But if you make a little flap, take a little bit of bone away. Oh, by the way, I try and do everything closed. I'm not a big believer in surgical extractions unless you have to. So we will learn about that in extractions lecture / lab. All right. Speaking of which, again, wicked resorptive lesions here and here. So I can crown amputate them, right? No, you can't. There you go. It's wicked here, right? Big lesions. This is going to shatter as soon as you touch it. Normal periodontal ligaments, normal root canals. This one even has infection here and infection up here. So unless you have severe resorption, you cannot do a crown amputation. But vice versa, this tooth looks pretty similar, right? You got this big resorptive lesion. You got the gum growing up here. If you take an x-ray, there's nothing left. There's no periodontal ligament. There's no root canal. There's no infection here. That's the mental foramina here. No periodontal disease. This is a crown amputation case. There are 4 radiographic findings that need to be satisfied before you can do a crown amputation. Number 1, no radiographic evidence of a root canal. Nope, don't see a root canal. I could see one here and here. If we had to take these teeth out, they would have to come out completely. Number 2, no periodontal ligament. Nope, don't see anything there. I do see one here, okay? Number 3, no endodontic disease. Nope, there's nothing there. And number 4, no periodontal disease. You see those? Crown amputation. Really simple, small envelope flap, cut it off, close it, you're done. 3 minutes, okay? But you can't do that here, okay? If you crown amputate these, this infection's staying. So my recommendation, put your thumb on your computer screen over the crown of the tooth. If you see anything that looks like tooth left, you have to get it out completely. Same thing here. these are not crown amputation cases because if you put your thumb over the computer screen, you can see normal roots. This one, however, is a crown amputation case. I can't make it any easier than that. Now, these rules work really well for mandibular teeth. Not always for maxillary. I typically can get most maxillary teeth out. Canines are an exception to that rule. But I want to show you this x-ray. I've seen this a few times just to make sure you don't get in trouble or the cat doesn't get in trouble. So here's a tooth resorptive lesion. You can see that's the lesion that's clinically. There's nothing left, right? This is a happy dance crown amputation case, right? That's what I did. Made it flat, took bone away, took the tooth out, and then I looked down into the extraction site. That little area right there is a little thin area of tooth, which is this spot right here. And if you look at it, there's the nerve right there. So whenever you do a crown amputation on a maxillary tooth, but especially the canine, look down into your extraction site. This is all bone. This has all been replaced. It's that little sheen. So I had to go down about another 3 to 4 millimeters to get that nerve out. So always check out your extraction sites or crown amputation sites of maxillary teeth. Okay. Another thing that cats get that dogs typically don't, and this is why we try not to take out maxillary canines, is lip trauma, called lip catching after the maxillary canine extraction. For some reason, cats' lips are really tight, and when you extract an upper canine, that upper lip will suck in and the cat will bite on it. My experience is about 30% of the time. That's anecdotal, no studies, but about 30% of the time we'll see these. About half of the cats that have it happen just deal with it. They lick and they get the tooth out, but they have a sore. They're not happy. They just deal with it. The other half of the time, so maybe 1/5 to 1/6 of the time you take out an upper canine, those cats are miserable. They're licking, they're pawing. I've had cats, honestly, a neurologist that I work with, she had her cat's maxillary canine extracted by the technician at the specialty hospital. She thought it was seizuring. It was so miserable. So try and avoid extracting upper canines if at all possible. Now, if it's got a tooth resorption or really advanced perio disease, yeah, you have to take it out. But if you have a fractured canine in a cat and an upper, do a root canal, because then you're not going to have to deal with the lower tooth. So send it out there to get it root canal. So like I said, most cats don't show clinical signs, but they really are. Some won't eat. Some will think they have TMJ issues. So this is what it looks like. This kitty is a long time ago. This is named Sid. And Sid had both upper canines extracted. And you can see every time he closes his mouth, I mean, cat canines biting into your lip, that's pretty miserable. And you can see the sores. The sores here from where he's biting into his lip. So Sid is miserable. He's not eating. He's not drinking. He is just an unhappy camper. So you have to deal with those lower canines. So how do you do it? Well, there's two options. One, you can extract it. Or what we prefer to do, because taking out lower canines in cats is pretty miserable, we like to do what's called a coronal amputation in either vital pulp therapy or root canal. Way less painful for the patient, keeps the strength in the jaw, you don't have to worry about breaking the jaw. The only negative is you should follow this out with x-rays, but in Brook's opinion, all animals should get their teeth cleaned once a year anyway. So here's a pre-op of these lower canines. And here's post-op. This is a vital pulp therapy on both lower canines, and that's what it looks like. So we just cut it down, leave a little bit in there. They do really well. So the big thing is, and again, you guys aren't going to be doing root canals, but this is why I think it's so important for y'all to be educated as to the possibility of these things happening. If you have to take out an upper canine, and either there's no option or the client declines referral for a root canal, you should tell the client, okay, the tooth has to come out. Your kitty's unhappy, it's infected, tooth has to be extracted. But there's about a 30% chance they're going to lip catch, and if they do, you're going to have to go to the specialist and get it treated. Or you guys could extract the lower canine. I mean, that's the other option. For me, when I am having to take out an upper canine, I always give the client the option. Do you want me to treat the lower canine today? There's a 30% chance that it's going to be a problem. And if it is a problem, then we have to re-anesthetize him and, we can treat it now or later. And most clients are like, just treat it. I don't want to deal with it. Sometimes I extract them, but 99% of the time it's faster for me to lower the height of the tooth and do a root canal. In your shoes out there, I would probably not take out a lower canine, but tell the client. That way the client won't be upset when they come back and you have lip catching, because you've done informed consent for the client. Eosinophilic granuloma complex is something that we see not infrequently in cats. And especially from the standpoint that we're seeing it more and more with some food allergies in some breeds. But the reason I really liked putting these slides in is that this cat was brought in for euthanasia because of the quote-unquote squamous cell carcinoma that somebody knew he had. Well, they hadn't biopsied it. So he came in on my watch. This is back in my general practice days, and I biopsied it, and it's an eosinophilic granuloma. This was a flea allergy. We treated him with some steroids. We put him on a flea medication, and cat's nose grew back. So just because it looks evil doesn't mean it is. Kind of the same thing here. This poor cat has had this lesion for 5 years. Went into its general practitioner, and they said, well, he's got squamous cell carcinoma, and he's going to die. There's nothing we can do about it. So the client didn't do anything. But 5 years later, she had inflammatory bowel disease and went in to see an internist that I work with. And they're like, well, what's this? And they're like, oh, yeah, he's got squamous cell. He's going to die. And the internist was like, I don't think so. So she sent it to me, and I biopsied it. And it came back eosinophilic granuloma. Certain ones of them can be quite destructive as well as productive. So how do I treat it? And when I always ask, Dr. Nemec, how do you treat eosinophilic granuloma? I refer it to a dermatologist. I don't want to mess with it. I don't like hand holding or paw holding. I don't want to mess with allergy testing and all that kind of stuff. So I booted it off to dermatologist. This was actually a food allergy. They changed the cat's food, got all of this to go back to being normal. And then I came back, extracted these 2 teeth, the canine and the 3rd premolar, created a flap, closed it, fixed it. So eosinophilic granuloma, if you can find an allergic cause, treat it. If not, cyclosporin is generally the drug of choice. But again, I don't treat these. I refer them off. And I would strongly recommend y'all do too once you find them. All right. So last couple things I want to talk about with kitties. Caudal stomatitis. Sorry, there's not a lot of new stuff out there. We used to call it stomatitis, but stomatitis is a misnomer. Stoma is mouth, itis is inflammation. You burn your tongue on a hot cup of coffee, you have stomatitis, okay? So it's just general inflammation. When we as veterinary dentists talk about caudal stomatitis, it's inflammation to the back of the mouth, where the jaws hinge together. Where the jaws hinge together, that is when you have caudal stomatitis. You have inflammation everywhere else. I'll show you some pictures of that in a little bit, but not of that area in the back. It's not the fossa. It's called caudal mucositis. That's what it is. So here it is. Inflammation where the jaws hinge together in the back. If you see inflammation there, don't waste the client's money biopsying it if it's bilateral. If it's unilateral, maybe. We'll talk about that in a minute. This is bilateral. This is caudal stomatitis. End of story. You don't need to do any other testing, unless you're looking at retained roots and stuff. Here's the issue. We don't know why it happens. We don't. We absolutely don't. There's been so many different theories over the years, FELV, FIV, calicivirus, Bartonella, plaque on the teeth, whatever. We just don't know. And honestly, what we kind of figure now is that it's a syndrome where multiple etiologies actually kind of look the same. And oh, by the way, it acts differently in Europe than it does in America. So I don't know. We don't know. Okay. So these are all the things. I already talked about this. These are all the things I already talked about that. I do believe that FELV and FIV make these animals worse, but I don't believe that it's the cause. I do believe that the inflammatory response to the bacteria and plaque plays a role. I think it makes it worse, but I don't think that it's the cause alone. So, like I said, it's an immune-mediated response to something. We just don't know what it is. And it also could be that they're reacting to more than one thing. So, we all know the typical history. The cats have a bad breath usually. They're painful. They're pawing at their mouth. They go up and try and eat, and they take a bite and scream and run away. They hide. They cry out when they yawn. They don't groom, so they get unkempt hair coat, and they drool. I mean, these cats are miserable. They're unhappy. And what does the mouth look like? Y'all know what it looks like. It's horribly inflamed, bright red cobblestone appearance that bleeds easily. I mean, classic stomatitis case here. Absolutely. It's everywhere. It's running down the attached gingiva. So it's kind of when you start seeing it up on the buccal mucosa all the way down. That's really another thing that you really need to start talking about. This is stomatitis and not gum disease. Just like that as well. Horrible inflammation. The inflammation is almost always symmetrical bilaterally, but not always. If it's unilateral, and we'll talk about this in a minute, I would biopsy that. I have seen cases of unilateral stomatitis, and I treat it the same way. I just extract that side of the mouth, but it's almost always bilateral. If it is unilateral, biopsy it just to make sure. So again, here's what it looks like running down the throat. You look up here, and again, this is where you start talking about the mouth isn't too bad, but this caudal inflamed area is horribly bad. I just don't know why it happens. So caudal stomatitis and perio disease will both have severe inflammation, especially that feline juvenile perio. The difference is the back of the mouth. So here's a classic caudal stomatitis, okay, where you've got the jaws hinged together, horrible inflammation even running down the throat. Same thing here. This is that cat post-extraction. See, notice no teeth left, horrible, horrible inflammation. But again, this cat has got horrible inflammation, right? Really overgrowth, really badly inflamed. No inflammation in the back of the mouth. This is feline juvenile periodontitis. I'll talk to you in a little bit about that. This is not stomatitis. I'm getting a lot of these referred in. And again, we can do extractions. We'll talk about that. But when you don't see the inflammation in the back of the mouth, this is not stomatitis. I mean, it is. I mean, it's stomatitis, but it's not caudal stomatitis. It's not what we think of that as that. But this is horrific. This is horrific gum disease, but it's not caudal stomatitis. Okay. Like I said, it's a clinical syndrome. I don't biopsy. Please don't culture. It's a complete waste in my opinion. Dental radiographs are critical, mostly to look for retained roots, to look for evidence of cancer, endodontic disease. To be brutally honest, though, I'm taking the teeth out anyway. I'm not doing selective extractions in these cases. And like I said, if you're looking at going, this isn't classic looking, it's unilateral, it's swollen more, there's bony reaction, yeah, take a biopsy. Why not? It doesn't hurt. The problem is it's just another anesthesia, another cost. So you can biopsy. I'm not going to tell you you're wrong to, but I just typically don't. But again, I'm pretty comfortable with my diagnostic. So ideally, we want to get these cats completely better, right? That's always our goal. It's not realistic with stomatitis, though. We can make them better. Sometimes these cats will go back and be completely normal and no inflammation, but it's usually just decreasing the inflammation to a manageable state. So we're talking about the two different types of therapy. There's medical and surgical. Medical means that you're treating them with drugs. Surgical means you're taking teeth out. If you're going to try medical management, which you're going to find out in a minute, I strongly recommend against. We need to get out any toothless disease, tooth resorption, endodontic disease, periodontal disease. And then the client's got to do home care, strict home care daily, which is miserable in cats with stomatitis. So it's not happening. And then medical therapy as well. So really, what do I do? What do most veterinary dentists do? We take out all the teeth, all of them. The studies have been done on molar and premolar extraction, not taking out the canines. If you have no inflammation to the canines, and I mean none, then I will give the client the option of leaving the canines and incisors, but it's rare for me. And I generally feel that our success rate is higher if we take them all out. One of the differences between general practitioners and specialists is that we will take a coarse diamond burr and get rid of the periodontal ligament, kind of do what's called a veloplasty, smooth the bone out really well. And that we think makes a difference. And again, like I said, if you're going to leave the canines and incisors, those animals have to have the most perfectly pink teeth. If they don't, if there's any hint of inflammation, I'm recommending that they come out as well. The vast majority of these animals will do well. I'd say 90 to 95% in our practice don't need any medication down the line. Some of them will still have some inflammation, but they're generally very happy eating, fat, and totally normal cats. I don't chase down a little bit of inflammation. The drugs are not super safe. So the only true studies out there that talk about it did caudal mouth extractions, and they say 60% of the time they get better. If we take them all out, and again, we're going to talk about getting them out early, we're closer to 90 to 95%. They really actually do well as long as you get out every speck of every tooth. So here's just some cats. I used to leave 2 canines because I didn't want to worry about breaking the jaw, taking out both lower canines at one time. I don't do that anymore. But this cat had horrible stomatitis. You can see how comfortable he is. Same thing here. This cat had miserable stomatitis. He was down. I don't know why we anesthetized this cat. We didn't do it. I think it was somebody else in our practice. And you can see there's no inflammation whatsoever. The vast majority of time, if extractions don't work, it's because roots were left behind. We see it all the time. We see it. It's very common. I mean, you see this cat here. Why they left this first premolar, I don't know. But you see all this inflammation here. Here's the roots, root. And there's the lower jaw. Yeah, they got all those roots out, right? Nowhere close. We pulled these teeth out, and this cat was a whole new cat. So please, 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 please take post-operative x-rays. Yes, I know that you got it all. I don't. I leave roots. I miss roots all the time. Once a month or so, I'll go, oh yeah, I got all that. Take an x-ray. No, I didn't. Actually, it just happened yesterday with a stomatitis cat. Oh yeah, I got it all. Yeah, I left a palatine root of an upper fourth premolar, so I went and got it out before we closed it. So please, 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 please take postoperative radiographs. Very rarely do these cats not respond 100%. And these are usually the patients that have been on steroids for a long time. We'll talk about that for a minute. And generally in that situation, we will use cyclosporin. Cyclosporins are our drug of choice, and it's the drug that Dr. Lomner did a study with in refractory cases. It actually typically works quite well. But the thing about it is, the reason in our experience, and again, there's no study, but this is in our experience, the cats that don't respond to extractions are the ones that have been on steroids for a long, long time. So what typically happens out there is that a veterinarian will diagnose stomatitis in a cat, and they will give it a shot at depot, and the cat will get better. And then 2 months later, they're coming back, and they'll just keep giving them shots. And 6, 8 months, year or so later, it'll work for 6 weeks, and then 5, and then 4, and then 3. And then it stopped working almost at all, or the cat becomes diabetic, or something bad happens, and then they refer it for extractions. And those just don't get better. They just don't. I don't know why. Again, they're cats. I think it has to do with the fact that when you have an allergic reaction, the more you're exposed to it, the worse it gets. So the key is get these teeth out early. The sooner the teeth come out, the better the cat does short-term and long-term in our experience. Laser therapy, zero scientific evidence, in my opinion, that it does anything. There was a study out of Penn, I believe, that looked at using lasers, and really it got better when they took the teeth out. There was a veterinary dentist in my area years ago that did a lot of it. There's no published reports, in my opinion, that support it, so I don't. Here's the only thing that's new out there, and that's stem cell therapy. UC Davis is doing a study, well, they were before COVID started, and they found about 50% of the animals responded decently. Some cats got just better. Some cats had no response. Some cats were in the middle. I'd say it's about 50-50 response. But it was only like 7 cats in the study. I know they've done more and had some success, but it's something that's relatively safe. I mean, it's somewhat invasive, but there's no drugs long term. So I think it's a reasonable thing to try. I'm just not thinking that it. Oh, by the way, though, post extractions, they don't do this until the teeth have been taken out. So there's really nothing. There is absolutely nothing that's been proven to help these cats before the teeth come out. Steroids will for a while. Okay. So that's surgical therapy. Bottom line, every veterinary dentist is going to tell you, as far as I know, get the teeth out, get them out soon, get them all out, smooth out the bone. Most of these cats will get better. If they don't, cyclosporin or holistic-y type therapy, the integrative stuff, supporting the immune system, has been shown to help too. Oh, by the way, on the medicinal side, I don't know if I have a slide in here, but Dr. Anthony did a study with 1-TDC, which is an esterified fatty acid, and they found some success with stomatitis cats, so it's something else to consider. The problem with medical therapy are several problems. Number one, they're daily oral medications. Pilling a cat's miserable. Plus, you add a painful cat, it's even more miserable. So it's really hard, and they also have significant side effects. So you really should be informed that this is the client should be informed this is a lifelong thing. There may be some significant side effects, and the delaying therapy just makes it worse. So if you're going to try medical therapy, if you've got a client that either can't afford or is just like, I'm not doing full mouth extractions, do a cleaning and get rid of any diseased teeth. Okay, any tooth that's bad on itself needs to come out. Different options for medical therapy. Antibiotics, I don't think do anything. I really don't. I mean, they may make it better for a day or two, but you're not going to keep them on antibiotics for life. So in my opinion, it doesn't help. Any oral antibiotics is going to be effective. You can even use Convenia if you wanted to, but again, it's not going to fix it. The mainstay is corticosteroids. If you're not going to be treating a cat with extractions, steroids are what works, especially injectable, Depomedrol, 5 to 10, 20 milligrams if it's not working anymore. About every other month, you're going to need to do it. It does work for a while, but you got to tell the client, we're going to do this until your cat doesn't respond, and then we're going to put them to sleep. I mean, I hate to be, succinct in that, but it's true. And there are other problems that can happen with steroids. I don't find that oral steroids are near as effective as injectable, probably just because the injectable are in the cat as opposed to oral. I mean, how many of them are actually getting in? So in my opinion, chronic corticosteroid therapy should only be done after you've had a really big heart-to-heart conversation with a client that this is not the best way to go, and make them decline full mouth extractions. Cyclosporin, again, like I said, Dr. Lomner did a really nice study several years ago that shows it's very effective in controlling resistant cases, but there's no real proof that it works before the teeth that are out. That's our drug of choice. I have to change this. It is approved in cats. Sorry, it is approved in cats. And you have to be careful, and you have to do blood levels and make sure everything's okay. Feline interferon. If you read the European studies, they're going to say it's great for refractory cases. I've used it in 20 to 30 cats. I've never seen any response. Neither has any veterinary dentist in America, as far as I know. You do have to order it from Europe. You cannot get it in the United States. You can get it through the compassionate use program. It's supposed to bring back a normal immune response. Again, it works in Europe. I don't know anybody that's had it work here. So there's no evidence also that it works as a primary treatment. Typically what we do is mix up one of the vials. You have to buy 5 and you use 1. You mix up the vials and you take half of it and you inject it interlesionally in the back of the cat's mouth. Then you mix it up, the rest of it, in 100 cc's. This is fun. 100 cc's of sterile saline or water, and you freeze it in 10 ml aliquots, and the client gives 1 cc a day for 100 days. Again, never seen it work. Okay. Lots of other options you might read about: lactoferrin, gold stars, levamisole, doxycycline, coenzyme Q10. You can try them. I wouldn't use any of the first 3. They're pretty scary stuff. But doxycycline, coenzyme Q10, I mean, why not use coenzyme Q10? So none of them have been proven to do anything. You can read online that they may have, but anecdotally, but I don't think in general it works. So bottom line is, pull the teeth, pull them now. We as specialists do them all in one go. If you want to split sides because you're doing them in practice, that's fine. I like to hurt them once and get it done. As specialists, we can usually get it done in about 2 hours, and I think that's reasonable. So it's a significant inflammation caudally. We don't know why it happens. It's clinical. You don't have to biopsy it anymore. And ideally, full mouth extractions are done because medical therapy is lifelong and frustrating. So a similar thing, and what we're seeing more and more, is juvenile periodontitis in cats. That means we're seeing severe inflammation in young cats before a year of age. We don't know why it happens, but in humans, there is an increased time of susceptibility in the puberty period. So it's an immune dip. We do see it in the Eases, Somalis, Tonkinese, Burmese, Siamese, and also Maine Coon. It's severe inflammation. It happens as soon as the teeth erupt. They can get gingival overgrowth or can just get severe periodontitis. Again, there's no caudal stomatitis, and it doesn't hurt. These cats are fat, nappy, and eating. There's 2 different syndromes, like I said. One's gingival overgrowth, which is a gingivitis. The other one is a very quick onset of periodontitis with bone loss, especially the molar teeth. So this is what it looks like. This is that hyperplastic look. These don't necessarily have bone loss associated with them, but that overgrowth will cause worse gum disease. But this is oftentimes, you can see this is about a 2-year-old cat, and he's got all this bone loss, especially the first molars. The first molars, top and bottom, typically need to be extracted. The hyperplastic as well. Again, you don't see as much inflammation, but you do see the hyperplasia that's going to worsen gum disease. And same thing here. So how do you treat it? Well, you treat it just like gum disease. That's what it is, but more intensely. This cat is just really prone to it. So if you have the gum overgrowth like this, you trim that back. I usually use a coarse diamond burr. Extract teeth that are bad. Anything that's bad, it's just going to get worse, so extract it. I've taken out first molars in 9-month-old cats, and then you've got to get that client on home care. And I mean daily home care, brushing ideally, using MaxiGuard, other different medication or rinses that will help. TD is a great diet. We'll talk about all this in periodontal therapy. Prognosis-wise, about half the cats will respond and be normal cats at 2. That means you're cleaning the teeth at 9 months and at 18 months and at 2 years and brushing every day, plus or minus rinses, plus or minus food treats and stuff like that. The other 50% will always be inflamed. If you need to, take the teeth out. It'll cure it. I've have one cat that progressed from this to stomatitis, but it's pretty rare. Last thing I'm going to touch bases on is cancer. Lumps and bumps in the mouth of cats are squamous cell until proven otherwise. So this is a sublingual squamous cell carcinoma in a cat, proliferative. Unfortunately, squamous cell in cats, I don't have good news for you. Nothing really works. If you catch it really early and it's on the mandible, like around the incisors, you can do a mandibulectomy and cure it. Maxillary, big ones, you got to have 2 centimeters of margin around this tumor. And that's 4 centimeters plus the tumor. Cats just don't have that much space. So they're not surgical candidates. Radiation doesn't work. Chemotherapy doesn't work. There was a report that most of my radiation oncologists that I work with don't believe in, but it was an accelerated chemotherapy radiation protocol. And it did have some success, so that's something to consider. But really, it's just a lousy prognosis unless you catch it really early. So that's a productive lesion, but I think you all need to know that most squamous cells are destructive. So this is a cat, and I see this all the time. He had these teeth extracted because they were quote unquote loose, right? So somebody extracted these loose teeth and it never healed. Why didn't it heal? Because they weren't loose because of periodontal disease. They were loose because of cancer. So you can see that this canine's being eaten away. All of this bone has been destroyed. This is the normal stuff up here. The bone's being destroyed here. So when you see loose teeth, half of the time or 99% of the time it's periodontal disease, but it could be cancer. Take dental x-rays. I hope everyone would be able to tell that this is not periodontal disease. And the last thing is, again, very classic look of squamous cell carcinoma in the mandible of a cat, the periosteal reaction here. These teeth are both loose, but there's no periol loss around it. All this kind of moth-eaten effect is what I talk about. So in summary, oral disease is incredibly common in cats. They almost all have something. They rarely show any signs. They are very unique. They have maladies not seen in other species. There's a lot of new stuff. There's things changing all the time. Sorry, I don't have better news about stomatitis. Keep up with the literature. Don't get frustrated. Just keep going. So that's cats and their mouths. So I hope you learned a few things. And signing off again from San Diego.